So good afternoon. I'm Stephanie Lenway, Dean of the Opus College of Business at St. Thomas, and it's my pleasure to welcome you to this First Friday luncheon. I'm grateful that I could serve as MC today because Dr. Wheeler's topic intersects with the work that we're doing at the Opus College. One of our strategic pillars is innovation in the business of healthcare. And we've set out as a goal the objective of reducing or helping to reduce the $1 trillion in waste in the administrative side of healthcare. We're doing this through a ragtag group that we call the Healthcare Roundtable that brings together representatives of different elements of the healthcare value chain, so instead of working vertically, they work horizontally. Also, this fall, we're going to introduce a new master's program in healthcare innovation that will teach students about human-centered design and lean and agile management. And if you've ever been in a hospital situation, you do appreciate how you'd like them to see the world from your perspective as you're sitting there sort of freaked out about what might happen, and also how efficiently you can go through the experience. At this time, it's my pleasure to thank our platinum sponsor for the First Friday series, Minnesota Bank and Trust, and our gold sponsor, the Opus College of Business Executive Programs. So let's recognize their contribution. So after our lunch, we will hear from Dr. Wheeler about healing healthcare. At this time, I'd like to invite Father Larry SNYDER to the podium to lead us in prayer.
Good afternoon, and let us join in prayer. Loving God, bless all those gathered here today as we come together in friendship and fellowship. We ask your blessing on this university, its students, faculty, and staff, and alumni. Thank you for the blessings of our individual and collective God-given gifts. Place in our hearts the desire to make a difference to our families, to our community, to our country, and to the many cultures and peoples worldwide. Give us balance in times of distraction and uncertainty. Help us move towards our goals with determination and always with an abundant sense of humor. Thank you for the food in a world where many know only hunger, for our faith in a world where many know fear, for friends in a world where many know only loneliness. We ask you to bless this food we are about to share, those who prepared it, those who serve it, and those who have worked to make today the very special occasion that it is. For all of this, we give you thanks. In the name of the Father, and of the Son, and of the Holy Spirit, amen. Have a good lunch.
Welcome back, everybody. One of the hardest parts of my job is just breaking up these lively conversations. But now it's my distinct honor to introduce Dr. Penny Wheeler, who is President and Chief Executive Officer of Allina Health. Prior to her appointment as CEO, Penny served as Chief Clinical Officer of Allina Health, responsible for leading the organization's quality and value agenda to the benefit of those served by Allina. Penny is a board-certified obstetrician gynecologist and served patients at the Women's Health Consultants in Minneapolis. She was president of Abbott Northwestern's medical staff and chaired the Allina Health Quality Committee and also served on Allina's board of directors. In addition to her current role, Penny is a trustee of the University of St. Thomas. She chairs the Minnesota Community Measurement Board and is on the board of Portico Healthnet. In 2012, Penny was named the Outstanding Healthcare Executive, based largely on her ability to form internal and external care collaboratives and positively impact community health. So I think the next page says, please join me in welcoming Penny Wheeler.
Well, first of all, if you don't recognize me from the picture up there, that was one of the 3 days that I wore makeup. So just know that this actually is that same person. And I felt warmly welcome, right away. I have people who I've delivered in this audience as an obstetrician, as a gynecologist. I've had all the family friends. I have the Barretts who knew my parents, who I couldn't have designed better parents to come up. I've had people that I've worked with, beloved coworkers, and I love this university and I'm grateful to be on the board of directors for such a forward-thinking university. So thank you for having me here today. So I always say in honor of my parents that my father was somebody who was a chemical engineer, worked for Ecolab. My mother was somebody who thought you could solve world hunger. So my role in my organization is to take practical steps, my dad, to idealism, my mother. And if we can do that in healthcare, then I think we'll have served the common good, to use a St. Thomas slogan, in a really powerful way. So what I want to do, and hopefully in the span of 30 minutes, so we have time for a couple questions anyway, is to talk about the tensions that exist, I think in this country around healthcare. Talk briefly about why we have to change and the imperative to change. Talk something about the activity that's going on in the country and here locally in terms of how healthcare is making changes, and then what we're trying to do, not only as an organization but as a community, to try to change that trajectory. So all that quickly as I can, because I'd love to get some insights and some questions from you as well. So let me just talk first about the underlying tension that exists, I think, in our country. I think to simply put it, we have this tension between two rights. We have had and enjoyed at the United States economic leadership that's allowed us to invest in very important things: social programs, safety programs, defense programs, security programs, educational programs, and so that economic leadership has allowed for a lot of good in our country. And then we also have this value of compassionate coverage for our fellow citizens. So this economic leadership and the costs of healthcare are actually pulling and tugging at this compassionate coverage that we want to provide for everybody here in healthcare. And so a lot of the tension, a lot of the politicalization of this is pulled essentially from that tension. And why? What's the imperative to change? Well, you guys all know this, but let me say it maybe in some different ways than you've seen it before. First of all, healthcare is incredibly fragmented. And if you had one picture to look at, as somebody put in front of us, and a lot of you know it, if I have to probably at least every day help navigate somebody through the healthcare system, when people stop calling me as a doctor and a leader of healthcare in this community to actually find their way to the right care provision, then I'll know we've done a good thing. But it's really fragmented. We don't give the preventative care people need. Chronic frail elderly might be in up to 19 prescriptions is not uncommon. When you have a care team that consists as an outpatient providers of 7 doctors and of 4 other providers, or if you're in the inpatient, of 27 different providers on average, and 1 of 5 people are being readmitted to the hospital, many of those which we could be prevented, it's fragmented. And we all feel it, and we've all seen it for that. I remember my dad when he had congestive heart failure at the end of his life, and he had to take, because of some of the fragmentation and misinformation, he took 3 trips to the pharmacy to get it right. And he looked at me and he said, okay, I love you guys, and can you do this better? Because I don't have that many days left. Thank you very much. So I don't really want to spend it this way. How about costs? Well, if you put things in terms of, and this is even a couple years old, so it's going to be more, but if you put things in terms of what we buy at the grocery store, This is what medical inflation has done, and it's pretty tough to bring home, for example, the pound of bacon anymore when it costs $130 a pound. So if it just gives you an idea of the ratcheting up of cost. And we'd love it if we could say that that cost was commensurate with quality of care that we have provided, and we cannot in this country. So we spend about 2.5 times as much, and we don't have appreciable quality outcomes that are differentiated from other countries. In fact, they're lower than many other countries. You don't hear very often anymore, well, I think we do some things extremely well. You don't very often anymore hear that American healthcare is the best healthcare in the world. It's costly for the outcomes that it's getting for the folks we serve. And we have this aging population too. This is a big deal. Healthcare costs are about $10,000 per person in the United States. Those are largely some of the costs for Medicare, and our Medicaid population come from people who are taxpayers or future taxpayers. You can see that today, there's about 2 of those for every 1 Medicare recipient. That's going to drop with the demographic change and the graying of America. That's going to drop substantially, which is threatening our ability to sustain these really critical programs for people. So there's a lot of reasons why, we need to change. And I say that, the time is ticking, and people, that's why you're hearing, and I'm going to talk a little bit about, gosh, what's happening in the market? How are people trying to solve this, going forward? So there's a lot of activity going on, people trying to solve this. I think you might have heard Warren Buffett when the J.P. Morgan, Berkshire Hathaway, Amazon thing was announced. Warren Buffett said that he called healthcare the tapeworm of the United States. It's not a thing we want to be identified with. I don't think we'll use that as our branding position. So we've got work to do. And there's a lot of people trying to do work. So let me just go through what's happening nationally. So the thing I'll point to is that we're seeing trends going from horizontal integration, where like is coming together with like, a lot of hospitals coming together with other hospital systems, to now more complementary or vertical, integration going on. And the 1 week here that really I'll point to is that in 1 week, in December, Dignity and CHI were coming together. They're now probably thinking about stalling that now, but Ascension and Providence are stalling. Dignity and CHI coming together. Ascension and Aurora and Advocate Health coming together to form the 10th largest not-for-profit. CVS bought Aetna and is in the process of that transaction right now. And those were all announced in 1 week in December. So as one of our board members says, if you don't think the world is spinning faster than ever before, you're not really paying attention. So, and we've had a lot of activity in our market too. You can see a lot of consolidations that have occurred. We were one of the organizations that didn't have a payer arm associated with it, one of the healthcare organizations. We felt like to do things like pay for cancer care coordination, the things that people relied on that weren't being paid for today, we had to serve all payers in the market, but we also had to be able to try to drive and disrupt things by able to pay for things that really matter for people, like care coordination activities and things like that. So a lot of activity going on right now. And we'll see how it all turns out. It's got a risk of further fragmenting things and driving up costs potentially, but it's also got the possibility of actually connecting things in ways they've never connected before. So, and we'll talk a little bit about that too, but lots of flurry of things going on because we've got a problem that we need to solve. And the problem really is this. One of my mentors says, the most important thing to remember in leadership is to never forget who and what you're serving. And who we serve are the community members of this community, and we serve our patients. And when they tell us what's wrong with healthcare, they will say this: it's cost too much, it's bankrupting us. It's really fragmented and complex, and it's a maze that we have to go through, and it's reactive. It's really about sick care and not about maintaining healthcare. So that's what it is. And this equation gets further complicated by the fact that and I'll speak about our personal, at our organization, our financial success does not always equate to the success of the people we're serving. So let me give you an example. We have a cancer care coordination program. It's beloved by people newly diagnosed and vulnerable with cancer diagnosis. They love that actually when they can just deal with their disease because there's somebody else who's connecting them to all the services that they need, going forward. We actually studied the program for 6 months. It turns out that not only did they think that these were angels on the earth, these cancer care coordinators, but it saved the community $1.2 million because 95 admissions to the hospitals were avoided. And we lost $600,000 because 95 admissions to the hospital were avoided. That's the problem with healthcare. Somebody one time, not part of our organization anymore, but there was one time where one of our presidents of one of our hospitals said, well, we didn't have a good month this month, it was in January, because we didn't have a good flu season. And what she meant was, sadly, not enough people got sick. We want to be rewarded when the community is healthy and support the community's health. And that's part of the problem is the financial model, which is one that rewards us for how many things we do to how many people, especially in acute care settings, hospital settings, is how we get rewarded today. And how we wish to get rewarded is by keeping the community as healthy as possible and keeping our beds as empty as possible and keeping people in their own places at nights. And I'll talk to you a little bit about that too. I think there's a way through it. There's a way through it. And I always say that on my tombstone will probably be something like the way to make health care more affordable for everybody in this country is by making it better. So if we do things that actually give better outcomes, better patient experience, better access, all of those things, all the good things over what its cost is, then we will do good things. And as one of my gurus, this is Michael Porter for those of you who love strategy. He's looking very evangelistic here, and he did, as he said this, he said, if that's the value equation, everything good essentially over what it costs, he said, focus on the numerator. The more you do things exceptionally well and consistently well, the lower the cost will be. And so I'm going to give you a couple examples of that, and first just show you, just in a bar graph what that might look like, if we did that. So what does that really mean? Well, what we pay for now is basically some inefficiencies and some waste in the healthcare system. Duplication of services that don't need to be duplicated, medical errors that could be avoided, unnecessary treatments that could be done, preventable complications, all these services that have about up to 30 to 40% waste in the system. And I'll give you a couple of tangible examples. One of our, we have people who are doing, for example, PET scans, a really expensive scan done, radiological exam done, for women who have stage 1 breast cancer. There is nothing in the literature that says that having a PET scan done when you have stage 1 breast cancer changes your prognosis whatsoever. There's just nothing there. We don't, we have a lot of gray zones in medicine. This isn't one of them. It just says it doesn't help the prognosis. Only we were doing them 14% of the time. These are the kinds of things that don't really add. They're unhelpful ways to the people that we're trying to serve. So there is a way through this by getting care more consistent and getting some of the things that don't benefit the people we're serving out of the equation. Couple other examples. This is in my area. So I'm an obstetrician gynecologist, as you heard Stephanie say, by trade. And we have, there's a lot of gray in medicine, but there's some things that aren't so gray. It's when somebody's pregnant, you should not electively induce their labor if they're within a week of their due date, because if you do so, you increase their risk of cesarean section, you increase the chance of the baby going to the neonatal intensive care unit, and you increase length of labor. And for all of you women who have had babies, the last thing we want to do is increase your length of labor. In fact, you are the reason why I adopted a child, because I saw enough of that, no thanks. So this is our work at, thank you. This is our work at trying to actually say, gosh, what could we do collectively? So we were, of course we said, and you talk to any obstetrician, any of my colleagues, and they say, well, we don't induce, anybody before they're a week within their due date. We know the science, we know that's right. Only when we measured it, as you can see, we were doing it an average of 14% of the time. You know, and sometimes, you know, it's like, you know, I remember somebody, you know, my husband's, away on trips, and this is the only time we can do it, and I want my repeat C-section, and it's 3 days before. You know, it's trying to accommodate people, but we were doing it, and that was increasing all of those risks I talked about. So we work together collectively as an organization. We at Allina, through our 12 hospitals, do 15,000 deliveries a year, so it's not insubstantial. And we got this down to now that it's a very low percentage where this is happening, and that saves about 235 women every year from having an unnecessary cesarean section, for example, let alone untold babies who don't have to go to the NICU. That reduces costs significantly, both in terms of human terms and in terms of financial terms. So those are the kinds of things you can do. Or how about this? This is why I'm so proud to live in a community like this. We work together, several organizations, Minnesota Hospital Associations and something called the Institute for Clinical Systems Improvement, for those of you who know it, work together to try to say, what could we do all together to try to prevent unnecessary readmissions to the hospital? So when we all work together to work on different protocols for how do you get people in who have had congestive heart failure, get them in quickly for an appointment, and how do you do all these things that actually prevent them from an unnecessary trip back to the hospital, you can see, this is one of those graphs you can see across the room, right? Well, we were able to reduce that significantly. So what does it mean? So this means actually we quantified this, almost 8,000 more people who didn't have readmissions to the hospital when we all worked together on this. And we also said it was over 31,000 nights that people spent in their own beds instead of one of ours. So that's the kind of, and actually when I gave this talk at a national conference, the people all broke out into a spontaneous applause. And they said, well, you can do that in Minnesota. It's like, well, you know what? You can do it other places too. So that was just remarkable. It shows what we can do together when we're all working collaboratively. This is something I'm really proud of too. So we have two what you would think of might be competing healthcare organizations. Allina Health, you know, we're lucky enough to take care of about 1 in 5 Minnesotans, and we bleed into Western Wisconsin, and also Health Partners, a huge force and a really positive organization that's very much based on the triple aim of healthcare, of keeping populations healthy, making sure that people have good experiences, and reducing the cost of care. We had we always talk about one of the things we wanted to do together as organizations is avoid a tragedy of the commons, where everybody's trying to self-optimize, do what they could do individually to compete and not do what they could do together. So up in the Northwest Metro, around Mercy Hospital, they had 4 clinics, we had 5. They had a health plan that had about 30,000 lives in it in that community, and they didn't have a separate hospital. So we said, well, what could we do together in that? So we partnered together, this collaboration among competitors, to be able to say, gosh, well, how about if we advance the quality together, we align on our quality pieces, and by doing so, we think we can actually reduce the cost of care, and we can share in the savings because we're paying the insurance for those 30,000 people, and then we can share in the savings model. How about we do that? So we started this about 9 years ago now, and we have gone from being above the cost in a community to below the trend line in the community, and we've advanced quality in terms of access to mental health services, in terms of using high-tech imaging the right way, in terms of making sure that people avoid unnecessary trips to our emergency rooms through some of the things we've done. So this is what we can do, and this is why I feel so grateful to be in a community who thinks this way. And again, when we would present this in other audiences, they say, yeah, well, that's Minnesota. And we say, well, you know, it can be a lot of places. So these are one of the things. And yes, we do compete, and it gets complex sometimes, but there's also room for collaboration, and that's what makes a difference. And as not-for-profit healthcare organizations whose mission it is to serve all, including those, and maybe especially those most vulnerable, these partnerships are really important. All right. So let me talk about kind of how we're then positioning this, you know, in our organization and thinking about it. And we're really thinking that healthcare was about what's the matter with you. That's how I was trained. I was trained to fix things, you know, that were wrong, and not to help predict, prevent, and support people and understand better what matters to you. So that's what we want to get, you know, a much more holistic view of what really matters to people, and position ourselves that we could care for all of you, which we'll define in a little different way, and do so for know you well. It's all about relationships at the end of the day, and do so for a lifetime. So So we say at Allina, we want to help you do essentially what's humanly possible. And so how do we do that? How do we set that up in our organization to actually be more about what's possible instead of just fixing what ails you? Well, I think we have to think about health in a different way. I never will forget a time when Atum Azahar sat at a blackboard. We were doing things we're located in the Phillips Powderhorn neighborhood with our headquarters. And she said, you know, I can tell you what you think is health is not what our community thinks is health. What you think is health is an absence of disease. What we think of health is feeling safe, having housing, making sure that we have jobs, and making sure that we can provide for our families, and making sure that all of that is true. So you should be thinking about health in a different way. And I'm grateful to say we're an organization, when we do kind of an archaeological dig about what makes us special and pertinent to the communities we serve, is that we think more about you than just your body part. So this is that holistic part, and I'll give you an example of how we're thinking about that. We really want to be the organization that thinks about delivering whole person care. So it goes beyond what your body needs and what that needs to what your emotional status is, to what you actually need in terms of what drives you in terms of your spirit going forward, and what connections do you have to your community. And we think if we don't think that way, that we're missing actually a lot of what health is, as Atum was one of those teachers, so profoundly that day. So we have assets that do this well. We have, for example, Courage Kenny Rehabilitation Institute that you might have heard of, that takes somebody from a stroke to actually thinking about, vocational training, activity-based things that they can do, and how they learn to, actually move from a devastating thing to how they learn to walk again, live again, and be supported again, and be more about their abilities than disabilities. We have things like the Penny George Institute for Health and Healing, which actually looks beyond, looks at nutritional factors, looks at stressful factors, looks at lifestyle factors that come into play. We're always humbled as healthcare organizations for something probably most of you know, that access to healthcare services, access to us, is about 10 to 20% of your health. The rest of it's on lifestyle supports, your environment, genetics, and those kinds of things. This country, though, is a little disproportionate. So we spend 90% of our dollars on access to healthcare services, and when only 10 to 20% is really affected health. So we have to think much broader about what is health really about, and what does it mean. So let me give you just drop down before we get into the end and any questions or guidance you have. Let me just get into an example of how do we make that live then? How do you be part of that? So we were one of the organizations that was lucky enough to be given an Accountable Health Communities grant from the Center for Medicaid and Medicaid Services. And this is, again, that 80% of somebody's health is determined of factors beyond traditional medical care. So we have these people who are coming to our clinics now, and hopefully we'll do it even more virtually in the future, coming in and filling out a questionnaire that goes beyond physical health into what else is going on in their lives. So they'll ask about 5 related social needs. How is their housing? What are their transportation needs? What are some of the issues around, are they exposed to any violence or any interpersonal violence? How about food insecurity? How about the cost of their utilities? What is going on in the rest of their life? And then there's a really, really wonderful program called NowPow, that if they identify one of these areas of need, that we can push a button and we can find out in their geography what's are available for them, and that are reliable and good services that they can go and get. And then that's part of how we then can connect them to needed community services and serve more of their health than just what their trouble breathing might be. So these are things that are going on now. We've piloted it so far at one of our largest clinics, almost like a little outpatient mini hospital. And we found a couple interesting things. First of all, we found out that people weren't having these discussions with the patients we were serving because they didn't know where to go with the discussions. And quite honestly, they felt uncomfortable having the discussions because they didn't want it to say like, gosh, I'm living high and you look like you're down and out. So they had trouble bridging those. So that was one of the things to get over. And then they have, people who work, as many of you know in healthcare, who work in healthcare clinics are inordinately busy. They thought, how am I going to embed this in my workflow, and how am I going to have these discussions, and how am I going to connect these services? How am I going to accommodate that in the tyranny of what we call a 15-minute visit sometime? So how do we do that? So there was some reluctance and some hesitancy to do that. And then they started to see the stories involved, and these all just come down to individual stories, right? So first of all, they found out that 40% of the people we were serving in the Coon Rapids Medical Clinic, a huge clinic we have, identified one of these needs. So that the needs were much greater than they had anticipated. And then they started hearing individual stories about somebody who couldn't get to a job because they didn't have headlights that were working and they didn't have enough money to be able to pay for getting that fixed. And they could, with a push of a button, say, you have transportation needs, you're needing this fixed in your automobile, here's somebody who does it on a sliding scale, and now that person has both jobs working, and they're able to support their family in ways that they envision. Or there's a wonderful story about a young woman who has 2 chronically ill sons, and she was having to not be able to make their appointments because of transportation issues, and because she actually, her washing machine went out. I mean, some people are living so close to the edge that she had to spend $10 a week to get her clothes washed, and this was a challenge. So by connecting her to those services, somebody fixed that and fixed her transportation needs, and now she can get her kids to the appointment, these kids that she loves, and she can support. And she said, you know, and again, you just don't know how closely people are living, you know, to the edge of things. She said in the story we ran about her that she was at the bottom, and now she's on the top of the world, just because we connected her to those services. So these are the kinds of things we can think about when we think about more holistically. We had to take this out of that clinic for a while because it's a Center for Medicaid and Medicaid Services. As many of you know, it comes with a lot of rules attached to it. So we had to pull it back to be able to, you know, refine it and do to those rules. The people in the clinic can't wait to get it back. So while they were skeptical at first, they saw the meaning behind this and can't wait to get it back. So that's just one example of some of the ways in which we can think and act and do things more fully for the people we're serving. And we want to be one of those organizations that, you know, getting back to the first slide, that not only helps to lead in this community, but helps to lead things nationally for a different way of looking at things. And by being better and connecting people more holistically to services, making healthcare less costly for those we serve. So I'll end with just a couple thoughts and see what questions you have. So this was at the Modern Healthcare about a couple of years ago, put this, the place you want to get sick, Minnesota, because of how well our quality of healthcare was. And so I think you see from the theme of my talk, I'm hoping that we're the place that people want to stay well. And that we actually become not about sick care, but about well care. We will always need, especially with this graying of America, really great, you know, integrated programs that deal with the sickest of the sick and most complicated thing. We'll always need, you know, acute care and hospital care. But we can think about how we can support people in the way that makes things humanly possible in better and more holistic ways than we have before. And we can do it by not just saying, but actually doing, as you could see with some of those community collaborative, what we've done on the quality side and how we're connecting people to resources in their community. And maybe I'll end with saying, and I often do, that one of my mentors, who's Don Berwick, who many of you know, said that at the end of the day, he thought that healthcare was more about love than anything else. Because if it's not one person, you know, trying to serve and reduce the suffering for another, and if that's not love, I don't know what is. So I feel fortunate to be in a, you know, healthcare organization that takes that very seriously and says how we can do things in different and better ways for the community. So thank you for your time, and I'd be happy to take a couple of questions too. If I didn't, hey, I did pretty well. Hey, that's good. Okay, thank you very much. I have to tell you a funny story. I'm seeing some of the colleagues, beloved colleagues that my spouse used to work with, and I'm really proud of my spouse who's on the Minnesota Supreme Court. But when I go to dinners with her, sometimes they ask me if I work outside the home. So I'm glad that you allowed me to not only you know, recognize that I work outside the home, that we're hopefully doing some good things. So, yeah, all right.
I'm Greg Cash. We spoke briefly before lunch.
Hi, Greg.
I was interested in seeing your graphs on cost containment and reduction of unnecessary procedures. Could you share your thoughts on outcomes-based reimbursement in the healthcare system, please?
Yeah, you know, I think that we're trying to, we say as an organization, we're trying to disrupt towards outcomes, taking more outcomes-based risk as an organization. And so there are various payment models that are coming and evolving to actually reward people for, instead of how many things we do to how many people, I'm going to put it simplistically to how well we do it and at what cost. But the models out there are still nascent to do that really well, and there are some challenges with them. We've partnered with the federal government. We were one of the pioneer accountable care organizations, went into next gen accountable care. We have partnerships with commercial payers on that side of things. You can see our Health Partners partnership, which is basically an ACO between healthcare organizations. But we have to, there's still some flaws with it. I'll give you an example of some flaws. We got to get that model right. It's a little bit different than the a la carte services that fee-for-service has been, and why fee-for-service isn't going away as quickly as we might want it to, because the new models are challenging. Giving you an example, we are committed to driving more value for our communities, as I've said. So we want to move into more of these outcome-based risk payment models that pay us for doing things well at affordable costs. But some of the models still have challenges. So we just actually, and it was just about killed me, we pulled out of one of those models, the Next Gen ACO with the federal government, because we didn't think it was a model we could be successful in. It tied us to really risk scoring. Risk scoring turns out to be a very important thing. Risk scoring that was done several years ago and wouldn't let us adjust that risk scoring risk, even though we were much better now with data and information at reflecting the true illness of our patients, so it would only let us do that so much per year. And it didn't recognize true insurance risk. So for example, the terrible flu season that this country has had this year. It didn't recognize that they asked us to bend the cost curve, and it didn't recognize some of those risks for which we had no control, and we're having to respond and cause greater risk. So the models are evolving. They're not perfect yet, and fee-for-service, is a simpler model, but it has its flaws in that it doesn't align with the best interests of all. You know, if you pay for outcomes per dollar spent, that's best for patients. That's best for the community and their resource. It's best for payers of healthcare, and it's best for the ones who want to provide the care. We just haven't gotten to models that are really completely solid and refined on that score, but we just have to keep moving there. It's the best way to do it. So thanks, Greg. Okay, yeah.
John Fisher, I'm OBGYN too, actually.
Oh, hi, John.
I've been in academics most of my career, so I love your talk, and I think you are right. We need to move this direction.
Yeah.
But how do we train the next generation of providers?
Yeah.
How do we fit that academic healthcare system into this,
Yeah.
which doesn't generate revenue and is very dependent on money coming into it?
Yeah.
Very little is going
I think it's a great question. I mean, I think one of the things we can do is we can think about training in a different way. So the question was, how do we think about training the next generation, working in this? And a lot of it in academic, rely on the education. A lot of research enterprise doesn't fully sit on its own bottom, right, line. So how do you actually invest in that? So first of all, I think training needs to evolve a bit more. Training and it kind of doesn't make any sense. Like I'm a triple gopher. We trained at the university, and we train in the School of Pharmacy, School of Nursing, School of Medicine, and then now that you've graduated, all work together. So it's all separate, and then you're working in teams. So things about working in more collaborative in teams, using data and information to improve care, looking at quality improvement science in a different way, and being trained in that. I think that all those things are important for what we need to be trained in. And I think there has to be a recognition that if we could actually take some of the waste out of healthcare and invest it in education and in research that not only deals in devices, drugs and devices, but in new payment models and in new care models that actually can serve in a better and more affordable way, like some of the ones I mentioned, we have to move in that direction too. So really important to support our educational institutions and the right research, not only drugs and devices, though, about new care models and also new payment models as well. So I think there's a few things we have to do in that regard. All right, yeah.
Thank you. I wanted to thank you. Your ideas on whole person care are so beautiful.
Oh, thank you.
But the paradox right, as people are talking about waste and preventing excessive treatments. I am an old nurse. When I started out, few people over age 80 with comorbidities were getting all the treatments that we give now.
Yeah.
Nowadays, people expect and demand. They want to be getting the best care, and they're getting wonderful care. They're getting hip surgeries, knee surgeries. They've got diabetes and advanced cancer and dementia. We are doing rehab on people who are 90 years old and haven't walked for years. We're doing hip surgeries on people with advanced dementia.
Yeah.
I do not see any of my patients saying, no, I don't want this care. So it isn't waste. It is people who, in our society, we all want the utmost in care and procedures.
Yeah.
And so we're talking about whole person care. These are people, my patients are all 80 to 100. We're doing intense rehab, which of course brings in money. Mm-hmm. All of the surgeries bring in money, of course. Mm-hmm. I'm getting paid for giving all these cares. Mm-hmm. But it isn't just waste. It's what all of you, anybody in this room who's over 55, is getting all sorts of cares and 1 million medications. Mm-hmm. So I love your idea on whole person care, but it's what people are demanding in healthcare now.
Yeah, and I think it's not, and thank you. I think you're right. I mean, I sometimes simplistically say the problem with healthcare today is the waste in the system is somebody else's revenue. So that's a fundamental problem. But I don't think it's a but, I think it's an and. You know, and so let me give an example where, you know, and I used to live this. I was a resident at the university, and I would be pushing chemotherapy on people who I knew, you know, had just few days to live, and there was no conversation with them about what their wishes were and how they wanted to live. We have a program called Life Course at our organization. It's for people anticipated to be in the last 2 years of life. And actually, a non-clinically trained care guy goes out to them and actually has prolonged conversations about what their wishes really are. When we have those dialogues, when we change the dialogue about what people really want and how they want to live, it changes everything. And I don't think that we've had adequate dialogue. The one thing we do in this country better than any country in the world is what you said. We give good rescue care. Sometimes when it's not wanted or beneficial to the people we're serving. We have to really understand what people want, what their wishes are. I don't think any of us want to end up, you know, 80% of people die in hospitals, 80% of people want to die at home. If we're having, you know, fuller conversations with people about what they really want, that's when you can solve that problem. Our Life Course program for people anticipating the last 2 years of life, we found out, first of all, most of the concerns that they have weren't related to their illness. They were related to family social circumstances. They were related to legal issues. They were related to financial things when they left. So connecting them to those things is a more holistic way. And when we did that program and supported them with those resources and that care guide, actually they were really happy. So their experience went way up. And the costs went way down. A third less people went to the emergency room when we understood that. 17% lower admissions to our hospital. Per person, per month in the research study, it was $900 less cost just by adhering to their wishes. And here's the tragic thing is, I don't know if we can get it paid for. We haven't been able to find a way to get that program paid for in the current reimbursement system. So I think there's a way around that. We just have to be smarter about, you know, what we support and more holistic dialogues we're able to have with people. So, and I don't know how we're doing on time. One more question. Okay, thank you. Thank you. But you highlighted very saliently some of the real issues here.
Thank you, Penny.
Yeah.
I don't know. Oh.
Thank you. as you pointed out here, Minnesota is blessed to have some great health care. I guess my question for you, there's different models of health care. You've pointed out Allina's. We also are blessed to have the Mayo Clinic here in this state. So I guess my question is how does your model differ from Mayo Clinic, and how do you collaborate together? And then what can the rest of this nation learn from either the Mayo model or your model here in Minnesota?
I think that, I think, first of all, let me tell you that, as much as I had Michael Porter on a stride, I'll be honest and say strategy and your part to play in your community and is pretty new to healthcare. We just basically have been following the mantra, build it and they will come. So everybody's been kind of doing things, similarly. You're going to start to see more divides about how well people position things in. I think, in talking to John Noseworthy, when we've had conversations, I mean, Rochester is, and Mayo is, really a destination center for people with the most complicated illnesses, coming in, the rarest of the rare coming into a fly-in center for that care. We hope that we can be, particularly since we live in, a metropolitan area, that kind of organization that takes care of you holistically, from having easy access to being able to take care of most of your complex things for a lifetime, in this community. So I think that different people, the university has to exist, and all these things are important for, primary research and education. I think that we're one of those organizations who wants to take this approach to care and make sure that we can do it for people over a lifetime rather than just a spot of coordinated care. Rochester does things really, really well, but for as a destination center. So that's how I'd say we differ. We do collaborate with Mayo, for example, in one of our markets, Owatonna. We have the hospital, they have all the clinic and providers, and we intersect, and we always go down there and talk about what else can we do, more effectively together. So that's an ongoing conversation. But there are also different parts to play by different organizations, and I think that actually benefits the community. All right, well, thank you very much for all your time. I really appreciate it. Yeah, thanks so much. Thanks, Stephanie. Thanks.